My name is Richard Newcomb. I'm a bone marrow transplant physician at Massachusetts General Hospital, and I conduct research on the patient experience for people with blood cancers going through intensive therapies like transplant. We've known for some time, both two randomized trials, that when you integrate palliative care with transplant, so you get palliative care clinicians to see people while they're in the hospital, that you improve quality of life and you reduce symptom burden, both physical and psychological. So that's a known established finding. And what I hope to do in this study was to tease apart for the people who respond, what are their factors associated with that. And we defined response as quality of life in the hospital. So we looked at early quality of life response. And the findings were interesting. I think we found there actually weren't a ton of socio-demographic factors associated with response. If people belong to a minoritized race, they seem to be more likely to have early quality of life response when receiving early palliative care. And then the other responses were actually more so based on people's baseline symptoms. So if you came in with a lower baseline quality of life, where you had higher symptoms of distress, notably depression, that those patients were more likely to have early benefit from specialty palliative care. And so you asked about the applications of this. I think this was an exploratory analysis, so it's hard to say anything definitively. But if we were to extrapolate this out, we were to say, if in the future we wanted to identify who are the people most likely to benefit, you can actually use patient-reported symptoms at the time of admission for transplant to sort of say, hey, you might be somebody who we really need to think about early palliative care from either a physical symptom or a psychological symptom perspective. One thing we know is that specialty palliative care improves people's lived experience. However, there just aren't enough palliative care clinicians so that everybody in a transplant or intensive therapy will get a consult. It's just not a feasible. We know it's effective, it's just not scalable. And so if you were looking to develop a program to say, all right, well, I know I can't give it to everybody, but if I survey people before they come into the hospital and get a sense of how they're doing, maybe that could be a way I can say, well, maybe I have 10 people coming to transplant and I know 2 are really struggling, even before we start conditioning. Maybe those are people that could benefit from specialty palliative care. So that could be one way to do it. The other approach could be we could train clinicians or transplant clinicians to be able to identify and actually administer some of those palliative care domains themselves. And I think that gets into some of the other findings of the study, in which we saw that it was the education and the coping pieces that patients who responded early to palliative care, those were the domains that they actually received more. And the good news about that is that you could train people on that. It's spending extra time at the bedside, talking about the expected course. It's figuring out people, how do they cope with things and how to better support them for their prior experiences, but with this new intense thing that they're going through. So those are just 2 potential ways you could take these results and sort of say, how do I build a supportive care program, whether it's targeted specialty palliative care or actually training transplant clinicians to deliver palliative care domains themselves. I think a very key role, I think if you go back to our specialty palliative care studies, the palliative care clinicians were either specialty palliative care physicians or actually nurse practitioners who were trained in palliative care. And so these domains, I think it's critical actually to involve people outside the physician world. So I think bedside nurses could play a huge role in it. I'm currently in the process of launching a primary palliative care study, and most of the people we're training are both the inpatient and the outpatient nurse practitioners. We didn't include nursing in that study, but that could be something that could easily be done. And I could say anecdotally, I think if you were to, who is already doing the best job at delivering some of the coping and education stuff, it is our bedside inpatient nurses. So I think that involving them in future work would be, I think, highly concordant with the work that we're doing. The one additional thing that I thought was quite interesting was that just how different people's responses to palliative care were. I think when you look at averages in terms of who is, like what on average is palliative care doing in the hospital, everybody's quality of life on an average basis goes down during transplant just because it's a hard process. But receiving palliative care was thought to mostly trying to prevent a very large decrement in quality of life or a very large increase in symptoms. And what was really interesting is that actually there were people in the responder group that their quality of life got better throughout the transplant hospitalization. So it's not simply that we were preventing decrement, but we were actually improving people's quality of life, which was not a finding that I expected. And again, it just speaks to the power of if you can control people's symptoms enough and give them enough education and power to know what to expect in their illness, then they will report a better experience, and that's really important. So that was really surprising.